use it via WhatsApp tool or
RX event, you can mute everyone except Dr. Neha.
Okay, sir.
And confirm once we are live.
Sir, we are good to go.
Thank you. Hello, everyone. A very good evening to one and all present here. And thank you for joining us for this very important event today. I am Dr. Neha Jain, and I welcome you all on behalf of MQ Pharmaceuticals Limited to this wonderful symposium on heart failure. I'm sure our eminent faculty members present here would agree when I say that heart failure is a complex ailment. And what makes it even more complex is its alarmingly rising numbers and the recent COVID pandemic. It is estimated that the overall cost of heart failure was around $108 billion in 2017. And we, the low and middle income countries, bear the major brunt of it. Given how COVID-19 pandemic has brought preventive medicine to the fore, we at MQ feel that this is the right time to reach out to our experts and understand best from them on the way forward for heart failures and together brainstorm for some potential solutions. We therefore bring to you a very rich and insightful session wherein we all will be discussing on various aspects of heart failure, ranging from its rising numbers and its management for iron deficiency in heart failure and in COVID era. I now take pleasure in walking you all through introducing our eminent faculty members for the event today. But yes, before I start, I want to take a moment and pause here and thank all our doctors who are with us today and those who are watching us live, who put their own lives at risk and who has helped India save through these trying times. A big thank you and gratitude from MQ Pharmaceuticals for you all. I now take pleasure in welcoming and introducing our course director and moderator for the event today. Our course director and moderator is Dr. C.K. Ponde, sir. Sir is a consultant cardiologist and head of Department of Cardiology at PD Hinduja National Hospital, Mumbai. Sir has always been a gold medalist throughout his UG and PG career. He's done a fellowship in interventional cardiology and electrophysiology from Brisbane, Australia. And he's currently the vice president of Indian Academy of Echocardiography. Sir is the recipient of several awards, namely Paul Harris Fellowship in 95, Olympian Health Award in 97, Rashtriya Manav Seva Puraskar in 99, and National Primetime Award in 2016. He's also received very lately the Inspiring Cardiology of India Award by Economics Time in 2020. He holds over 100 publications to his credit. I now welcome our key speakers for the program today. Our first key speaker is Dr. Sanjay Mittal, sir. Dr. Mittal is a Senior Director of Clinical Cardiology and Research at Medanta, Medicity, Delhi. He is an ex-senior consultant in charge of non-invasive cardiology of Indraprastha Apollo Hospitals, Delhi. He is a national lead investigator, principal investigator, and co-investigator in various crucial trials, namely the Prominent Trial, Select Trial, SCORE Trial, and Paradise MI Trial. He'll be giving a power talk on effective screening for iron deficiency in heart failure. How far are we from the ideal? I now welcome and introduce our second key speaker for the day. Our second speaker is Dr. B.G. Muralidhar. Sir is a founder chairman of Trinity Group, and presently he is the chairman and chief of cardiology at Trinity Hospital and Heart Foundation, Bangalore. He's a pioneer in the field of primary angioplasty and has performed over 40,000 angiograms and 15,000 angioplasty in his career spanning over 2 decades. He holds very special interest in patient education programs and is actively engaged in many of them. He is a recipient of various prestigious awards for his meritorious services in the field of medicine, namely the Shivaji Award for Karnataka Mahasabha, Rajiv Gandhi National Award, and the prestigious Dr. B.C. Roy Award. I now welcome and introduce our third key speaker for the event today, Dr. John Christopher, sir. Dr. Christopher is the Director of Cardiac Imaging at Care Hospital, Banjara Hill, Hyderabad. He was the Director of Cardiac Imaging at Care Hospital, Hyderabad. He's done a fellowship in cardiac imaging from Birmingham and Women's Hospital Harvard Medical School, Boston, Massachusetts, USA. He's a principal investigator of international trials like MEDIC, Icarus, Conserve, and Ischemia, in charge of Big Picture Registry, and also the executive member of Asian Society of Cardiac Imaging. Sir will be giving a power talk on changing trends in heart failure, the must-have strategies for place in India. I now welcome and introduce our last speaker for the day. Our last speaker is Dr. S.N. Rautrai, sir. Sir is a professor and head of the Department for Cardiology at SCB Medical College, Cuttack. He is trained at prestigious universities like University of Rouen in France, at Germany, and at AIIMS, Delhi. Sir was a convener of rheumatic heart disease, executive council member of CSI, and an honorary secretary of CSI Orissa in the past. Sir is a life member of Cardiology Society of India and Indian College of Cardiology, and he has various original and review articles published in reputed national and international journals to his credit. Sir would be giving us a power talk on COVID-19 and heart failure, the do's and don'ts for risk minimization. With that brief introduction and welcoming of all our eminent faculty members, I would now request our course director and moderator, Dr. C.K. Ponde, sir, to kindly give his opening remarks.
I'm sorry, I was caught on the wrong foot. I think this is the first time I have completely forgotten. I must say this, in my entire life, I have never forgotten any academic commitment. This commitment was probably one of the exceptions. I have learned hard way how to handle this in future. I'm really sorry. And today's entire symposium is on heart failure and heart failure related therapy. And today the concentration is on the ion therapy in heart failure. And there are 4 didactic lectures, one followed by the other. And we have already heard, we have got a great national faculty. They are all people who are extremely capable, extremely knowledgeable, and of repute to enlighten us upon various topics in this symposium. So I think without further ado, we should start with the first talk because we have limited time. And may I invite our first speaker, please?
Yes.
Yeah.
Yes.
Dr. Sanjay?
Yes.
Yes.
Dr. Ponde, good to hear from you. Welcome to all delegates and fellow speakers and cardiologists. The topic I'm going to discuss today is, just to start the conversation actually, effective screening for iron deficiency in heart failure. As was very much clearly evident that heart failure is definitely a growing problem of the world, specifically when we have better treatments of acute cardiac emergencies in the form of acute angioplasties and all. We are having much more heart failure in the patient population. And one of the things which we all know is iron deficiency is one of the big comorbidity which is very frequently evident in heart failure population. As much as 50% of people with chronic heart failure would have iron deficiency, and it is much more in acute decompensated heart failure, as much as 60 to 70%. There could be so many reasons. We all know that why the iron deficiency is so much frequent in heart failure. It may be worsening the heart failure, and poor prognostic identification could be there because of iron deficiency presence. But also the heart failure itself would lead to worsening of iron deficiency, and that's why the vicious cycle can go on. They're significantly associated with mortality and morbidity, both. As much as 40% increase in mortality in patients who have iron deficiency heart failure as compared to those who do not is seen. Timely detection and appropriate management is known to correct large things in time, which means if we correct iron deficiency in time, we can reduce the rate of hospitalizations because of heart failure. We can improve the quality of life, and we can also improve the effort tolerance in heart failure population. What are the recommendations? World over, the recommendations are loud and clear. it's very evident that even the European guidelines, which were released lately in 2016 as well as 2021, very clearly spell out that iron deficiency should be important diagnostic workup tool in all patients with newly diagnosis of heart failure. And they level it as 1, and level of evidence is C. So they say that it should be done in all class 1 indication for all patients with heart failure with reduced ejection fraction who have diagnosed for the first time. And the practical recommendations also are that iron deficiency should be diagnosed in all patients with existing heart failure, particularly if they are symptomatic despite receiving optimal background therapy. And they also recommend that we should check for iron deficiency once or twice in a year in all those patients when they are in the follow-up. Why? Because that could develop during the course of the heart failure, as we discussed. And this is what I was talking about, the 2021 European guidelines. When we look at a person presenting to us for the first time as potential heart failure population, we need a workup. We know NT-proBNP or BNP is class 1 indication, level of evidence B. But look at these blood tests. Iron status has to be measured in all. It is, again, class 1 indication, level of evidence C. And that should be done in all the people. So what is now important in our country? Where are we? Well, in our population, there is some data to suggest that the iron deficiency is much more frequent as compared to the Western population. One of the studies was saying as much as 80% of people who present to us with heart failure with reduced ejection fraction have iron deficiency. Well, unfortunately, we have pockets of data, but not large-scale data to actually communicate what is the population-based data on iron deficiency, but at least it's more than 50%. So the importance is, when should we do the iron level estimation or iron deficiency estimation in all people? Are we doing it right or are we not? In my opinion, there are a lot of divides when people come to my heart failure clinic. I've been running the heart failure clinic since 1999. And what I see is people presenting to me, they, despite the fact it's class 1 recommendation, they rarely get the iron studies done, and they do not have the diagnosis of iron deficiency that they have or not. And there are questions that when should we do it? I think in my clinical practice, and I would request the fellow cardiologists here to opine if they have anything else to comment upon this. But I would have a checklist of the items I have to definitely investigate whenever a person presents to me with heart failure. This includes, obviously, anemia, hemoglobin level, but beyond hemoglobin level, without anemia itself, iron deficiency can happen, and iron deficiency assessment could be done. Iron level, ferritin level, total iron binding capacity, I do in all my patients who present to me for the first time, and make it a point that I repeat it at least once a year, and especially after 3 months if I have to give them iron therapy. So when do we screen? I think everybody should be screened for iron deficiency whosoever is presenting to me with symptomatic heart failure with reduced ejection fraction. How do we do that? We measure the iron levels. They may be anemic or they may not be anemic. And once we detect it, how do we treat, and what are the choices of treatment? Well, there is enough data, and in my clinical practice, for sure, there's only intravenous iron therapy, which is to be given whenever the ferritin level is less than 100, or if it is between 100 or 300, when we check the transferrin saturation, which has to be above 20. If it is less than 20, then it means iron deficiency is there, and we have to rectify the iron stores so that the outcomes improve in the form of functional tolerance, exercise capacity, and hospitalization for heart failure. And I use ferric carboxymaltose in my clinical practice. And I mean, once we start the discussion, it would be important to hear what other people do in our country. Do we measure the effect of iron therapy? Well, yes, in my clinical practice, I do measure it after 3 months. Maybe I have to repeat it if iron deficiency is severe. Maybe I have to repeat 1 gram of iron after a week of initial iron therapy in many people. There are a lot of things which can be varying in our country. There are various level of interactions or patients' presentations. There could be tier 1 hospitals, tier 2 cities, or tier 3 cities, where there could be differences in management strategies for iron deficiencies, looking out for iron deficiencies. We may have public hospitals not doing so much, or corporate hospitals not doing so much, mainly because of the cost implications. And there could be a divide in the cardiologists versus general physicians, because yet there is a common understanding if the hemoglobin level is normal, there is no iron deficiency, which may not be true. And this is something which is important to be understood, that iron deficiency can be there even without existing anemia. So the other thing which I would hurriedly go through is iron deficiency screening in heart failure. There are roadblocks. And as I was indicating in the previous slide, the routine screening for ID is not practiced and recommended. And I have seen that many a times until the patient presents to my clinic. Maybe not 5 or 6% people would have had their iron assessed. And that is why I make it a point to check it out whether it has been done or not. If it is done, fine. If it is not done, make a rule that it has to be done. Ineffective screening leads to huge burden of unidentified cases. And unidentified cases would also mean that we are doing a disservice to those patients by letting them have higher chances of mortality, worse physical fitness, worse chances of their repeated hospitalization for heart failure, which can easily be controlled or reduced by correcting their iron therapy. We did a study also in our hospital where we randomized people who had iron deficiency to receive oral versus intravenous, and we found that there was no way the VO2 max, exercise tolerance, 6-minute hall walk distance, and their function, quality of life, everything was better if we were given intravenous iron. Lack of rich clinical evidence for Indian patients. Unfortunately, that is very much true. As the previous slide was mentioning, in India, there is a lot of divide in the cardiologists versus general physicians, in private versus corporate hospitals, in tier 1, tier 2, or tier 3 cities. So those things are there. And so the data is not yet available in large scale in truistic form in our country. Poor knowledge and inadequate resources. Yes, not every lab is doing iron studies also, and understanding how to define iron deficiency in heart failure also is a major hindrance. And the other important thing is that most of the patients are paying from their own pockets. Insurance coverage is poor, which means this is an additional burden at times, and that's why many of the physicians are scared of advising unnecessary process, so-called unnecessary procedure. But mind it, in my opinion, this is a necessary procedure which would help in outcomes. In our country, dietary insufficiencies, infections, besides the other factor is that there are a lot of times the people with heart failure would have chronic kidney disease, which also would worsen the absorption of iron and also the assimilation of iron into the bone marrow. There could be inflammation and overactivity of the renin-angiotensin activity, which could lead to the iron deficiency, and lack of transmitting of iron into the cells, causing a lot of problems. So that is something which has to be understood and practiced in clinical sense. So the last slide, before I end my communication, start the debate and discussion, is what we should do. It's easy to say that it should be done, but I think in my opinion, it has to be started at individual level. My level, it is important to educate whosoever is coming to me as a student for studying heart failure management. I do make a point that iron deficiency assessment is important. Whenever I give lectures, this is important, and it should be incorporated into national recommendations. We have recommendations for children, we have recommendations for women, but for heart failure, I don't think the government priority list is still there. Probably it's still focused on the nutritional deficiencies and infectious diseases much more. We have to expand the iron portfolios, which means that all these sorts of items which should be available. There should be labs geared up to do iron studies so that the patients as well as physicians can use that in their clinical practice. So this is something which is important. And the last but not the least, in our population, we are a poor population, but we have to somehow how inculcate a good insurance practice and government health schemes, which should be able to support the IV iron supplementations. Now that we have so much of data that it does help in outcomes reversal of heart failure population. Thank you. And I think it's a good point now to hear from the other panelists about what their opinion about their practices are.
Yeah, thank you, Dr. Sanjay. That was a really a brilliant talk on the how to screen the population and why to screen and what are going to be the benefits and what are the roadblocks in this. And I think the three fundamental points which you made very clear is iron deficiency in heart failure does not equate to anemia. So patients with normal hemoglobin or near normal hemoglobin can still be substantially iron deficient. And it is not only the improvement in hemoglobin which makes the people feel better with heart failure. It is something different, and our further speakers are going to throw a deeper light onto that. The second thing which you made it very clear is that the screening should occur in every patient with heart failure when he's diagnosed. And you start your guideline-directed medical therapy with the fantastic 4, as we call them, the 4 pillars of heart failure therapy. And I'm sure that in a short while in guidelines, probably IV iron therapy could come as a 5th pillar of HEPREF therapy, because it improves the quality of life. It reduces recurrent hospitalizations, as you said, in patients with HEPREF. The third point, which you made it extremely profoundly clear, is that once in a year minimum, these patients should be screened for heart failure, even if you're screened earlier at the outset and treated them. Particularly, I would add a little thing on that, particularly those patients who are on anticoagulation for atrial fibrillation, those who are on dual antiplatelet therapy because they have undergone coronary interventions in the course of their therapy. These people should be screened perhaps more frequently, once in 6 months maybe, for iron deficiency. So thank you very much for your talk, and we will take all the audience questions at the end. Now, could we invite Dr. Neha, our next speaker?
Sir, our next speaker is Dr. Muralidhar. Sir would be talking about iron IV ferric carboxymaltose. What makes it the ideal choice for treatment? So,
Yes.
And sir, should I share the slides?
Yeah, please. Please share the slides.
Yeah, please give me a minute. I'm making it full screen, sir.
Sure,
So,
thank you. Go ahead. Next slide, please. Good evening, everybody. When we look at the morbidity and comorbidity and association with heart failure, iron deficiency has got a much stronger association with heart failure and the outcomes rather than anemia. As it has already been made clear, it's not just anemia that we are interested. We are more interested in iron deficiency. It is probably different from anemia alone. A lot of patients may not have anemia, but they will have iron deficiency. Next slide, please.
Yeah. If you are finding challenge, you can just send me this presentation.
And the iron deficiency is actually, there are two types of iron deficiency that we would see in anemia, in heart failure. One is absolute iron deficiency, and there is something called functional iron deficiency. The absolute iron deficiency, where the actual values itself are low, and that is because of, has already been said, malnutrition, malabsorption, GI blood losses. Whereas the reduced iron deficiency because of mobilization, that leads to functional iron deficiency because of inflammatory response and cytokines and other blunted responses to EPO. So the system may not respond to EPO, and these patients have got a functional iron deficiency. Next slide, please.
Sir, give me a minute. I'm just.
Sure. Take your own.
Yeah, I'll just something is.
You need to go to slide share, and from there, I think.
Yes, I'm just.
Yes.
Sir, is this yours?
Yeah.
Next slide? Yeah.
Yeah, that's fine. That's fine. Whenever this is the normal level of normal serum ferritin level is more than 300 micrograms per deciliter, and the transferrin saturation is more than 20%. If you have a serum ferritin level of less than 100, that would be classified as absolute iron deficiency. But you have a serum ferritin level between 100 to 299, but you have a serum transferritin level which is less than 20, that would become a functional iron deficiency. So we need to differentiate. There are two types of things that are available. These are the two parameters that we need to measure before we diagnose iron deficiency, whether it's absolute iron deficiency or functional iron deficiency. Next slide, please. And as I've already been said, almost 50% of the patients have got iron deficiency, anemia, iron deficiency in patients with heart failure. And that leads to decrease in functional capacity, quality of life, and outcomes. And the European Society of Guidelines has given this for the diagnosis and treatment of iron deficiency. So if the serum ferritin levels are, as I said already before, it is less than 100, it is called absolute deficiency. And if with a normal or a near normal serum ferritin and a transferrin saturation of less than 20, would qualify as functional deficiency. And both are indications for iron treatment. Next slide, please. About 50% of the patients have got iron deficiency in heart failure almost. In our country, they say it's even expected more. So nearly half of them are suffering from iron deficiency. Next slide, please. It's a problem which is grossly underdiagnosed and undertreated. When people suffer from heart failure and iron deficiency, they suffer from 10% reduced exercise capacity, 20% decrease in the quality of life, and 40% increased risk of hospitalization, recurrent hospitalizations. Next slide, please. And also mortality increases in patients with heart failure. There is a clear association between iron deficiency and mortality in heart failure. And the mortality increases when the iron deficiency is present or the curve starts separating. Next slide, please. So should iron be at the heart of our concern? Yes. As has already been alluded to, it should be one of the primary pillars of treatment in patients with heart failure to prevent recurrent hospitalizations and to improve the quality of life. And addressing iron deficiency at an early stage will probably lead to sustainable improvement in exercise capacity, quality of life, and reduce recurrent hospitalizations, and also help in reducing the mortality. Next slide, please. How do we treat these patients? Iron therapy for patients with iron deficiency anemia. This is a challenge. A lot of people think that by giving oral supplementations, it will work like how it does in pregnancy and other malnutrition patients. Unfortunately, it doesn't seem to work in patients with heart failure. Iron deficiency in heart failure is best treated only by intravenous iron therapy, and oral iron therapy in any form does not help these patients. There is enough data and there is evidence to say that intravenous iron therapy is a treatment of choice in patients with heart failure, and not oral therapy. Oral therapy doesn't seem to help these patients. Next slide, please. We have various randomized control trials to give us the evidence of summary. We have trials like FAIR heart failure trial, confirm heart failure trial, and effect heart failure trials to show that there is symptomatic improvement in the quality of life and functional capacity when we treat these patients with intravenous iron compared to placebo. We also have from a Ferium heart trial and FAIR-HF2 trial and heart FAD trial, the morbidity and mortality is also improves when we treat these patients with intravenous iron therapy. So we do have clear evidence with randomized clinical trials showing that there is improvement in symptoms, quality of life, function, morbidity, and mortality when we treat these patients with intravenous iron therapy. Next slide, please. The IV iron is the only valid treatment option for patients with iron deficiency in heart failure. And the commonly used and what we use regularly in our practice is intravenous ferric carboxy maltase, what we call IV-FCM. This should be considered in symptomatic patients with heart failure with reduced ejection fraction, wherever there is an absolute deficiency or functional deficiency. This is a class 2A level of recommendation with the evidence of A. So this is recommended across the board in all patients with iron deficiency in order to alleviate heart failure symptoms and to improve exercise capacity and quality of life. Next slide, please. And how do we treat these patients? So initially you do a hemoglobin check to see whether the hemoglobin is high or low. And even in patients with normal hemoglobin, you should check iron levels. Even if the hemoglobin level is 15, it doesn't mean that their iron levels are normal. And then depending upon the weight and recommendations, you can go. Or generally what we do simply in our clinical practice is give them 1 gram of IV-FCM and repeat a test after 3 months or 6 months to see anything more needs to be done. Otherwise, most of the patients do well with a single injection of 1 gram of IV-FCM. Next slide, please. So to conclude my talk, iron deficiency, regardless of hemoglobin level, is an indication for supplementation in symptomatic patients with heart failure with reduced ejection fraction. Only intravenous ferrous carboxy maltose, that is FCM, has been demonstrated to be safe and effective for iron depletion in these patients. Oral iron supplementation is not effective in iron deficient patients with heart failure. Morbidity and mortality have been launched to verify whether the iron depletion improves the outcomes in patients with heart failure. Thank you very much.
Thank you, Dr. Mudidhara. That was a lucid viewpoint of use of IV carboxymaltose for the patients with HEPREF who are iron deficient. Now, 3 things from your talk which people should take home, the audience should take home is: 1, don't go only by hemoglobin. Whatever your hemoglobin, you must do serum iron studies to diagnose iron deficiency in heart failure. So if you have a serum ferritin which is between 100 to 300, but your transferrin saturation is less than 20%, you are still iron deficient. And when the iron ferritin is less than 100, definitely you are iron deficient, and you must treat these patients with iron therapy. The second point, which is extremely clear, you made it very, very clear, is oral iron supplementation has no role whatsoever in treating these patients with heart failure with reduced ejection fraction for correcting their iron deficiency. It is only IV iron, and the ferric carboxymaltose is the molecule of choice. The third thing which you made it clear is 1 gram of single IV dose is usually sufficient for at least a period of 6 to 8 months in majority of these patients. Probably Indian patients will need this supplementation a little more frequently than the Westerners because of our dietary deficiencies and so on, and that probably we'll have to have our own data to project and see what our patients need at the end of the day, how frequently they need this IV iron therapy. So thank you very much indeed, and we'll take the discussion and the questions at the end of all the 4 talks again. So Dr. Neha, can we invite?
Yes, sir. So now I would request Dr. Christopher, sir, to please share his screen, and we are going to listen about the trends of heart failure and the strategies in place for India.
Is the screen visible?
Yes.
Good evening, everybody, and the respected chairperson and my fellow panel members and all the physicians out there. And also thank you, MQ, for this opportunity. A very interesting talk that has been given to me about the changing trends in heart failure. And the first thing that we must look at is the prevalence. And if you look all over the world, except maybe in sub-Saharan Africa, heart failure is out there, and it's out there in a very big way. We're all very concerned about the COVID epidemic and recent infectious epidemics. But what has been very stable over the last 20 years or so is heart failure has been relentless. And as you can see, it is there everywhere. And the prevalence is anywhere between 0.8 to about 2%. And in every kind of community, north or south, it is there in big measure. What is also interesting is that heart failure, like any degenerative disease over the last 30 years, continues to advance and progress in terms of the prevalence. And what it also does is that the years lived with disability also keep on increasing and reaching new heights. So it is not a static disease. It is a disease which continues to progress. What is also alarming, and we saw that with the COVID vaccination status, is that people in the high socio-demographic areas, like the northern part of the world, including the European continent and the mainland United States, is that there is a gradual but definite decrease in the incidence of heart failure. So much so by 2030, it will occupy less than 25% of all the cases. But the exact opposite is happening in low to middle countries, especially India is a clear, big representative of that. And there is a steady but definite increase in the number of heart failure cases and also in the prevalence. And this is a very, very alarming thought because of the clear disparity in the healthcare infrastructure. What is also seen is that in the higher socioeconomic countries, the heart failure is restricted to fairly elderly population, as you can see here in blue. And while heart failure is bad, but it is clearly affecting people who are out of the economic growth engine. While in people in the lower socioeconomic and middle socioeconomic areas, you can see that heart failure initially started off in the elderly, but seems to be coming down and is now afflicting the younger population who are the growth drivers for the GDP of these countries. So age, again, is a major problem. When you look at the, again, the incidence of the least deprived people, that is the higher socioeconomic group, you can see that at every level of increased socioeconomic, there is actually a lower incidence and also a decreasing trend over the last 10 years. While the people with the highest socioeconomic deprivation, including countries like us, you can see that we start fairly ahead, and despite all the interventions, there's a relentless progress and increase in the incidence of heart failure over time. Now, if you look at the comorbidities, again, over a period of about a decade, you can see that the different colors are the different comorbidities, as you can see on the right. And as we move across, the comorbidities are actually increasing in patients with heart failure. And that makes heart failure a especially complex problem to deal with, especially for clinicians, physicians, and cardiologists who are not trained and equipped to do so. What is also disarming is that individual comorbidities as a cumulative percentage of patients are also increasing. Notably, anemia that we just talked about is actually increasing in a big way. And obviously the big three, hypertension, atrial fibrillation, and ischemic heart disease, and also diabetes, continue to rage onward and become important comorbidities in the treatment of heart failure. And thus, it's a complex requirement for a physician to deal with heart failure today than it was about 10 years ago. If you look at the WHO statistics, about 17 million deaths are responsible by cardiovascular disease alone, and they contribute to 1/3 of the global deaths, and this number seems to be steadily increasing by the next 10 years. What is also bad is that it is occupying a significant chunk of the economy, and even in largely developed countries, the economic cost seems to be quite huge, running into about 20 to 30 billion in the UK and over 500 billion in the United States. And these are countries wherein there is actually a decrease in the incidence, or at least a stabilization in the incidence, compared to lower economic countries like India, where there is a significant increase. Hence, there is an urgent need for solutions for managing. Now, in India, this was a very nice write-up by Dr. Prabhakaran some time ago, along with one of the invited faculty from the American College. And they looked at different ways in which in India we could arrest the progression, or at least change the tangent of the progression of heart failure. And they identified 3 major points which the government along with the private sector could look at. And the first one was the primordial prevention, wherein a significant decrease in salt intake would actually decrease the incidence of heart failure. And we had a very interesting experience with the US American physician group, wherein we found that the state of Ohio does not allow restaurants and fast food joints to place a salt shaker on the table unless a customer specifically asks for. And I thought that was a very interesting way to bring salt in the cornerstone of someone's sort of diet. The second thing is to restrict the availability of tobacco and also put in punitive taxes on the sale of tobacco, and that would again help in the prevention. Coming to the primary prevention, the strategies include availability of anti-streptococcal antibiotics, which are freely available, penicillin prophylaxis to be more available to the younger population, to use the standard drugs like ACE and ARBs very early when there is an asymptomatic LV dysfunction, and also aggressive lowering of blood pressure and aggressive lowering of sugar, because as we have seen, diabetes and hypertension are significant drivers of heart failure. In the secondary prevention, the use of non-physician health workers, and as one of my co-panelists already said, the use of a checklist in patients with heart failure, especially in the outpatient and the inpatient, will really help us record the data, help us get a very good pan-Indian database, because as cardiologists, we are quite busy in the care of our patients. So by having these trained, centrally trained non-physician health workers, we could get the burden of heart failure very accurately, and also the interventions that we do could be documented, and that will help us, if not change the trend of heart failure. The important thing again is the usage of the 4 standard drugs, or the 4 pillars of heart failure, which include the RAS and ARNI combination, beta blockers, the MRA and SGLT2. And despite their very good availability and also a significant price drop, informal studies have shown that less than 30% of our heart failure patients are actually on all the 4 drugs. And again, it is very important to initiate these drugs very early and complete the initiation by the end of the 4th week. Otherwise, the inertia for starting remains significant, and also the up titration becomes a significant problem for physicians, and that leads us with drugs which are, if not being used, but used in inadequate doses. Newer ways and strategies, including usage of the digital digital sort of platforms. In fact, if some of you have heard the budget, there was a big noise about using the digital currency. And we have realized that after the COVID and also denominatization, we found that cash is becoming less and less used, and there's a significant adoption of the digital platforms. So here the digital platform can be used to observe the patient, the way he's taking his drugs, his salt, his exercise, and all this could go into the database for the physician at the clinic. And that could lead to something called a differentiated care, wherein an individualized care and template can be given to that patient, so that if he is a little salt excessive, specific things about salt can be talked to him. If he's eating a little too much sugar, that can be talked about. If he's deficient in exercise, that can be stressed upon. The importance of using generic drugs, the importance of using the digital platform to send reminders, where most of us are all on our phones all the time. So I think this is a great medium to keep patients connected. Early follow-up visits, calling them early, talking to them, making sure that the goals are short-term rather than long-term, because short-term goals are more concrete. And also maximizing placebo effects of the drugs, including good interaction by the family members. And finally, the use of, again, digital platform to show the patient the benefit effects of the drugs, the benefit effects of all the therapies that we are giving. And the visual plans can be very, very gratifying for the patient. Infrastructure obviously has to be strengthened to expand the level and reach of specialized care. Patient education, again, is a big, big priority, because once they're educated, then everything comes from within, and they are more likely to adopt technologies, drugs that will help them. It's very, very important in India to have low cost but high impact models. And some of the examples that most of us are using are wrist-worn devices. In fact, all the big technology companies are pushing these wrist-worn devices, which are now getting cheaper and cheaper by the day. And also we have very good cardiac monitoring devices, which are just simple skin patches, and they act as very good telemetry. And again, these are rentable and at a fairly lower cost than what happened about 10 years ago. Teleconsultation, again, is improving access, especially to the elderly, especially to those people who are confined due to lockdowns and the COVID problem. And it is allowing a whole series of platforms which are now more accessible to the Indian patient as ever before. Thank you very much for your patient hearing.
Thank you, Dr. Johan Christopher. As usual, you have thrown a very vivid light on what can be and should be done in treating patients with HEPREP. In fact, the Kerala Heart Failure Registry, the registry had shown us that in India, the 1-year mortality of HEPREP patients approaches 40%. And hardly 1/4 of the 1/4 of the patients leave the hospital after getting admitted for acute decompensated heart failure with guideline-directed medical therapy. And that's really very sad and very, very frustrating. There are several reasons for that, and you have alluded to few reasons already in your talk, but I can tell you two more reasons are: the heart failure is never perceived by the patients and his family in the same seriousness the way cancer is perceived. The moment you utter the word cancer, the entire family, patients is all tuned to treat the patients in the best possible center with the best possible oncologist. They can liquidate all the family's resources to aid to the patient's treatment. Whereas when you talk about heart failure, all that you hear is कुछ नहीं, थोड़ी सांस फूल गई थी, 2 दिन आईसीयू में भर्ती थे और अभी घर आ गए. That's all about it. So I think patient education, and that was a crux point you made, is very, very important so that they stick with therapy. And adherence to therapy of this heart failure therapy is extremely important if you want to achieve a reduction, clinically meaningful reduction in heart failure outcomes such as heart failure hospitalizations and mortality. So it's very, very important, Dr. Johan. You are really made us wiser. And Dr. Prabhakaran's paper about how in India we can make a change in the outcome of heart failure patients with reduced ejection fraction is very, very important. Thank you very much for that. Now our next speaker is Dr. Rautroy.
Yes, sir.
Dr. Neha, can you please invite him?
Yes, sir. Yes, sir.
Sir, are you sharing your slides from your end or what?
You have my slides are visible or not visible now?
Not yet,
Sir,
sir.
we
Not
can
yet,
see
sir.
the white screen just.
Okay. Why it is?
Again, we can see white screen, sir.
Sorry.
So when you start your screen share, okay.
Yes.
Yeah.
Now,
Okay. Yeah. Good evening, everybody. Respected moderator, fellow faculties, MCure Pharma, and logged in doctors. Because my talk is something different. As if now we are discussing in this evening mainly the role of iron, particularly in the field of heart failure. This has come because of the pandemic, this importance of heart failure, particularly COVID pandemic. But to our all good luck, the COVID pandemic is receding and chances of getting severe with Omicron is very less. Anyway, these are the high-risk subsets, patients, those who are older, people who have underlying medical conditions like heart disease, diabetes, obesity, lung disease, kidney disease, and on cancer medications. Pregnant women, these are the high-risk subsets. If you see here, along with that, if there is systemic inflammation, coagulation abnormalities, severe illness and multi-organ dysfunction, and immobility, that also add to the risk. And the complications are myocardial injury and myocarditis. This may be acute myocardial infarction, heart failure and cardiomyopathy, arrhythmia, shock, cardiac arrest, and venous thromboembolism. We see, all of us know this coronavirus enter the cell through this angiotensin converting enzyme receptor and TMPR repressor. And after that, these slides everybody must be seeing several times. They direct invasion or they cause inflammation by affecting mainly lungs and secondary to the heart. And this can cause involvement directly or by producing a cytokine storm. With the cytokine storm, all three things happens. There may be acute coronary syndrome, there can be heart failure, and there can be independently arrhythmia. If you see, the potential contributing factors and mechanism of worsening the heart failure in patients with COVID-19 include increased oxygen demand, myocarditis, stress cardiomyopathy, ischemia or infarction, cytokine release syndrome, and elevated pulmonary pressures and venous thromboembolism. All these things, this is an integrated slide you see, but mainly they work through different mechanisms, increasing the metabolic demand, increasing the thrombotic activity, increasing the sympathetic activity, and renal impairment all lead to either ischemia, myocarditis, LV dysfunction, or pulmonary hypertension, right ventricular failure, and arrhythmia all lead to heart failure. If you see, this biomarker here is important because this cardiomyocyte injury is quantified by cardiac troponin T or I. Hemodynamic stress is quantified by BNP or NT-proBNP. And if you take into account this cardiac troponin T or I or BNP or NT should be concentration should be interpreted as quantitative variables. In the absence of typical angina or there is ischemic EC changes with mild elevation less than 3 times that of the upper limit of normal, do not require any treatment or further investigations regarding this. And management of myocardial injury in presence of COVID-19, you see if there is increased biomarkers, either you suspect ACS or suspect myocarditis. If no risk factors of CAD, no significant EC changes, and global wall motion abnormality in echo, then you suspect myocarditis and consider or confirm, which are difficult by doing MRI at these situations. But however, if the patient is hemodynamically stable, optimize preload and afterload, and gradually add guideline-directed medical treatment. The other part is acute coronary syndrome. But all they say, if the hemodynamically unstable, they may need inotrope supports or mechanical ventilator support, mechanical circulatory support. Important variables in the management of patient with COVID. You see, there may be involvement of the lungs, which add to our heart failure problems. Patient may have hypoxemia, and that also add that need to ventilation. Coming here, this fluid, here the fluid is, we'll have to keep the fluid balance in the negative part. That is very important. And electrolyte balance has to be maintained and congestion had to be reduced. And heart, particularly if there is cardiotoxicity and of this COVID drugs. So if the patient requires COVID drug to, at the present point of time, no COVID drugs is being used even as per guidelines. So there may be cardiotoxicity, or we'll have to look for the interactions. And myocardial damage, that is seen by markers. And if there is pre-existing disease, they are more prone to develop. Without pre-existing disease, there can be myocardial damage also. Here is very important, systolic or diastolic dysfunction. There are small studies which have come up because doing echo in such patients is difficult. Situation because many times echo machine is not available and otherwise. And this, it has been seen quite a large number of patients do have diastolic dysfunction, a diastolic heart failure. Because there is no ejection fraction remains normal, but patients have symptoms and signs suggestive of heart failure. If you see, regarding this distinguishing early between the viral lung damage and acute pulmonary edema, that is important. It is easily done by CT and ultrasound of the lungs. And patients treated with the ACE inhibitor ARB presented a less severe disease and levels of IL-6 and higher absolute CD3 count and CD8 T cells, and showing that this is beneficial. Initially, there was a thought, then there are concepts that this may be harmful, but it has been found to be beneficial in small studies. It has been shown that mortality is also less those who are on ACE inhibitors or ARBs. Use of diuretics in patients with COVID-19 must be carefully monitored together with the administration of the with fluids to maintain a negative fluid balance. That is very much important because in situation of acute heart failure, we'll have to do this. And there may be interactions may occur between the drugs used for congestive heart failure and the ones currently used for COVID-19 management. And it's antiviral therapy, particularly they have side effects and cardiotoxicity, but by at present point of time, it is not preferred to use antiviral therapy. Here you see, I will concentrate here. The management of patients' advanced heart failure can be done by telemedicine. Telemedicine has to come because in such situations. So use video or phone calls or televisits, involve caretakers, daily weight and track heart rate and blood pressure, discuss medication adherence, suggest monitoring for signs of COVID-19, reinforce hand hygiene and physical distancing, and social isolation. Use remote monitoring devices. And as we know, ACE inhibitor is rather indicated. And if you see here, you can summarize like this, the management of acute heart failure. Acute heart failure may complicate clinical course of COVID-19. Underlying mechanism of acute heart failure in COVID-19 may be acute myocardial injury or infarction, or inflammation or myocarditis. There may be ARDS, which may contribute, acute kidney injury, hypervolemia, all these things, and tachyarrhythmia can also contribute to this. And COVID-19 pneumonia may lead to worsening of hemodynamic status. So clinical presentation, pre-existing severe morbidity, comorbidity, and chest imaging are important. But the most important, the same treatment strategy for acute heart failure can be given to patients with or without COVID-19. Your treatment strategy remains same. Coming to the chronic heart failure, the risk of COVID-19 infection may be higher in chronic heart failure patients due to advanced age, lack of immune status, and associated comorbidities. In heart failure patients suspected of COVID-19, routine clinical assessment, temperature measurement, and all these things are done. ECG to look for arrhythmia, myocardial ischemia, or myocarditis. Chest X-ray to look for cardiomegaly and COVID pneumonia. Other lab tests like ESR and CRP can suggest. However, the ambulatory patient with stable heart failure with no cardiac emergency should refrain from hospitalization should refrain from hospital visits, should be treated at home. So guideline-directed medical therapy, including beta blockers, ACE inhibitor, ARB, or sacubitril valsartan, or MR antagonist, continued be there for the treatment, or should be continued for treatment of patients with chronic heart failure, irrespective of COVID-19. Telemedicine should be considered whenever possible to provide medical advice in stable heart failure patients. Coming to prognosis, we all know the COVID-19 infection negatively affects the patients with pre-existing cardiovascular disease. Heart failure patients are at especially increased risk due to the reduced immunity, general frailty, and reduced hemodynamic ability to cope with more severe infection. As per some studies, patients with existing cardiovascular disease generally experience a poor prognosis and mortality, maybe in the range of 10%, small studies. Early diagnosis and management of complications is crucial. We'll have to diagnose and treat correctly. So heart failure is one of the most common chronic cardiovascular disease. According to recent studies, these patients are susceptible to more serious clinical symptoms and higher mortality rate with COVID-19. Management involves comprehensive cardiologic monitoring, ensuring early detection and clinical and instrumental pattern, and anticipate complications and modify strategy of treatment. Guideline-directed medical treatment is to be followed. Antiviral drugs should be avoided. If used, side effects, drug-drug interaction, and cardiotoxicity has to be kept in mind. With this, I finish my talk. I will have discussion at the end.
Thank you, Dr. Rautroy, for the overview of management of heart failure in patients with COVID-19. That has been a challenge, I think, for most of the centers because, as you said, availability of an echocardiogram machine itself in the COVID facility is a challenge. And I have been doing the COVID administration in Hinduja for the last 2.5 years, and I know how bad it is. We as doctors are happy to do our own profession, our own work. But when administrative work is given of COVID, I just simply got crushed under that. So it is very difficult to get echocardiograms done of COVID patients. Secondly, to get them treated with supplemental oxygen, not only oxygen, but sometimes NIV and ventilator has been a challenge because we had to raise the entire 7 floors of one building, convert into a COVID facility with a separate exit, separate entry, separate AC duct and vents, etc. within a span of 3 weeks when the pandemic started. So it was a big, huge challenge. So I'm quite sure that we will have a lot of discussion on this issue of management of heart failure in COVID patients. And you made it very clear that when troponins are high, there can be 2 possibilities. Either it could be COVID myocarditis and the acute coronary syndrome. And many times to differentiate and to take a call on that right at the outset could be very difficult unless you do serial troponins, serial ECG changes, and then probably a truth will emerge that we are dealing with either an ACS or a COVID myocarditis. Again, getting MRIs of these patients is a challenging task. You will have to have the MRI machine probably sanitize after every single patient before the next patient comes in, and that too will have something like a cath lab, a negative pressure air conditioning system, so that the surrounding area is not getting infected or soiled. So it is very difficult task really to manage these patients. Thank you very much for that talk. So let us start the discussion. Neha ji, are there any questions from the audience in the chat box?
No, sir, there are not no questions as such.
Okay, so let me start the ball rolling with Dr. First, I will invite Dr. Sanjay Mittal. Dr. Sanjay, are you there?
Yeah.
Can you throw some light on, let us say you get a patient with acute decompensated heart failure admitted to the hospital. You stabilize him. Now he just come out of the ICU. He's no more on oxygen. He was very wet on admission with frank pulmonary edema. Now pulmonary edema is cleared off. Now he's shifted to the ward. And he's on just a small dose of beta blockers, diuretics. You're about to institute ARNI, etc. And you now do the iron studies, you find him severely iron deficient. Would you give iron supplementation to acute decompensated heart failure in hospital before discharge? That is my first question, sir.
That's a wonderful question, Dr. Pandey. As I was discussing during deliberation also, there are so many reasons for iron deficiency during heart failure and acute decompensated heart failure. One of them is hemodilution, excess fluid overload. So once I have ensured that there is no more fluid overload situation or hemodilution, and is definite iron deficiency, as soon as the person is shiftable to the wards, I would do the management of giving IV iron in that person.
Yeah. So, Dr. Sanjay Mitra, are there any data? Because see, 2 of the trials of heart failure in iron therapy in heart failure have shown that drugs like ARNI and drugs like beta blockers work better in heart failure with reduced ejection fraction in patients who are not iron deficient versus those who are iron deficient. What is your take on that?
So you're right, because again, I can say it in some other way that beta blockers and ARNIs are better in non-iron deficient people because of on iron deficient people because of the fact that there is a higher event rates expected in that population as well. So the margin or the difference is going to be early seen in this kind of population. But what I'm trying to say is it's not one or the other. It's basically one and the other, which I'm talking about. There's no question that I have to give ARNIs and beta blockers and SGLT2 inhibitors. Now that SGLT2 inhibitors just before discharge, when the person is about to be discharged, I'll start. I don't wait for them to come to the outdoor and all. So there's no question. 1, 2, 3, 4. The 4 pillars are independent. That has to be done. But the question was, at what point in time would I give the iron supplementation? I would say not in acute decompensated phase. As soon as I'm convinced that there's a real iron deficiency and there's no hemodilution effect, before discharge, I'll definitely pursue to give them iron therapy.
Thank you very much. Thank you very much, Dr. Sanjay. That was great. Dr. Mudidharan, sir, we had one patient really, in your guidelines, you said, patients with hemoglobin of 15 grams and above, there is not much of a data. But 2 patients we found in the last 7 months in this COVID pandemic, one was COVID positive, one was negative. Both had iron hemoglobin levels of 14 grams and above, and both had ferritin levels of less than 100. What would you do in such patients, sir?
Well, though the guidelines don't recommend, if the ferritin levels are less than 100, I would go ahead and give iron therapy. Because we just can't be slaves to the guidelines and ignore the clinical situation. I think I would go and treat them with iron infusion.
Because see, there was a lot of debate in our ICU about between the hematologists and the treating intensivists and us to give iron or not to give iron. Finally, we lost the battle and they did not give iron to these patients and send them home. So I'm asking you because their ferritins were in the range of 60s, 60s ferritin.
I think that's an absolute deficiency. I think we need to give them iron therapy.
Yeah. The other question is, there are some patients with chronic systemic infections, like patients being treated for tuberculosis, lung tuberculosis or lymph node tuberculosis, patients with sarcoid, patients with collagen vascular disorders. These patients, you get quite many with ferritin levels of 350, 400 or even 410 or something like that. But their transparent saturations are 12 and 14. The other side of the story. How would you treat these patients?
It's again, ferritin is one of the indicators for inflammation. So if there is a chronic inflammation, ferritin levels will be very high.
Correct.
Even in COVID patients, we have seen ferritin levels very high.
Yes.
So that being the situation, we really need to, again, here probably we'll have to take transferrin saturation as an important criteria. And if these patients are asymptomatic, we should treat them.
Yeah.
See, the guidelines, what we have said, 100 and less than 20 is applicable for the majority of the population. But there are always exceptions to the rule, where as a clinician, we need to make our decision And that is why one of the topics I said was your experience. So we have been treating these patients for 20 years, 25 years. I think we need to put our clinical decision making as a priority and say that these patients need to be treated and we need to treat them. We can't just go only by the guidelines.
Yes. So these two points are very clear, Dr. Mullidhar. You made it for the audience too who are listening, that if you have a patient with near normal hemoglobin of 14 also, but the ferritin is less than 100, and the patient is in heart failure with reduced ejection fraction, you must correct their iron deficiency. On the other side, patients with chronic systemic disorders who have, because of chronic inflammation, fallaciously elevated ferritin, but less saturation than 20%, must also be considered for treating with IV iron. And the last question, which is again haunted my mind for quite some time now, is this, that there are, we give dose of 1000 milligrams of iron, or 1 gram of iron. Is this dose weight dependent? Suppose I have a frail patient, 40 kgs in weight with heart failure, an elderly woman, 40 kgs in weight. Would you give 1 gram or would you reduce it to 750 or 500 milligrams, sir?
See, there are guidelines based on the weight basis also, but I think majority of the patients will do well with a single gram. And what we have seen in clinical practice is with 1 gram, most of them do very well. But if you have to strictly go by the guidelines, okay, we can take the weight and go by the measurements and give them around 750, probably that would do well. But I would say, see, for a clinician, for a community physician to treat, probably 1 gram would be a rule of thumb, and they can give that, and most of the patients would do well.
Fantastic. Yeah. So that's fine. That's good. No, because this question was again asked in one of our clinical meetings. I don't remember exactly, around 8 or 9 months ago, and I didn't have an answer. So I think rule of thumb, we should go and just give, and a little bit of extra iron will not produce much of a harm. Dr. Rautroy, I will invite you now to throw some more light on how serial rises of troponin make difference between COVID myocarditis versus an ACS.
Yeah. Actually, this is very important. I didn't touch the ACS part, but that is very important because many patients, they come with ACS, this may be type 1 or type 2, because we'll have to look for 3 things. That is, one, you told this is serial troponin measurement. We'll have to see a rise and or even fall is also quite important. And second is regional wall motion abnormality in the echocardiography. And regarding this other parameters like specific EC changes to particular region, say hereditary or like that. So accordingly, we'll have to correlate with the ECG and echo our changes in the biomarkers. So at biomarker only we cannot say. At the same time, if there is NT-proBNP or proBNP raised, more likely that patient is having myocarditis with possibility of raised LA pressure or arterial pressure, we can say.
Yeah. Thank you very much, sir. Dr. Johan, now can you throw some light on doing an MRI in this patient? How does a diagnosis of myocarditis based on interstitial edema and late gadolinium enhancement patterns differ between an ACS, non-ST elevation ACS, and myocarditis with a cardiac MRI?
I would believe, thank you, sir, for that question. I think if there is one investigation that will clearly separate, although we do know that kinetics of troponin are a little different in both, but if there is one gold standard, although as you said, it's a little challenging, but we have had a big series of MRIs done for cardiac patients during the COVID, and we have somehow managed, is the MRI has 2 very specific sequences. The first one is rather simple because it does not even require an IV administration. So if you have a little sick patient, you can just get the patient in maybe in about 10 minutes. We have something called a T2 weighted study. And we also have a T1 parametric map. It takes about 8 to 10 minutes to do, provided the patient can remain a little still and have a 5 to 6 second breath hold. Now, what it will show is that the T2 weighted images appear extremely bright. Generally, in most myocarditis, and I still don't know the exact reason, the infralateral part of the left ventricle is usually afflicted, especially if it is a viral bone vector. In almost, I would say, 80%, with a slight increase in the mediastinal nodes, which are again seen very easily, very quickly on the MR. While the patients with ACS of any kinds, the edema is in a very specific vascular territory, either the circ territory or the RCA territory or the LAD, and that will anyway be evident because you have the ECG and the echo to support before you go in for the MR. So let us say the patient has a 1 AVL V5 V6 ST depression, and you find it in the infralateral wall, the edema, and the regional wall is also in the same area. That's obviously a circ OM territory. Or if you have an anterior septum involvement on the echo and the ECG, then if the edema is there, it's pretty much a water shut case of an ischemic etiology. And again, here the edema, if it's done well, will start from the subendocardium and be very, very constrained by the vascular territory. Now, in a myocarditis, on the other hand, the edema is very patchy, it's very diffuse, generally more common in the infralateral, but it could be anywhere. Does not fit any kind of pattern that you would expect in a vascular etiology. And it is extremely bright, much more brighter than what an ischemic etiology can cause. Because as you know, one of the important things of myocarditis is that there is a lot of swelling, and the swelling is very generalized. So you have the heart is almost shining at you. So it's one of the things that you don't miss, even if you're a rookie operator. Now, the second thing, and the T1 parametric maps, which now some of the new MRI scans have, again will show fairly high T1 values in a non-vascular territory in a myocarditis. And again, for various reasons, it's more restricted to the infralateral. One of the clues and the tips that I have got after a little bit of experience is that there is always almost an involvement of the pericardium in a myocarditis. A thin film of fluid and a little bit of pericardial enhancement. This is the edema sequence. It's never only the myocardium because, as you know, it's non-vascular. It spills on into the pericardium, depending at what stage you image, which is never the case in an ischemic etiology. So the moment I see the pericardial involvement, the infralateral point, a thin film of fluid restricted to the lateral wall or infralateral, I know this is myocarditis. Now, going further, if the patient is more stable, you're able to give an IV gadolinium and then image after 10 minutes. What we do see again is a very subendocardial starting point and very much fixed to the vascular territory. So I'm looking at a anterior septum and anterior wall involvement. If it's LAD, very clear cut. And remember, it starts from the subendocardium and then moves outward in different directions. So subendocardial involvement is critical here in a vascular etiology and being fixed by its vascular space, like we discussed, LAD, RCA, or so. But in the myocarditis, what you see is very patchy, scattered, mid-myocardial with subendocardial sparing, moves into the subepicardial zone, moves into the pericardium. There's pericardial enhancement, and that's clearly what is there in myocarditis. And these two patterns that I've described, I would almost say with a lot of conviction that it's very, very definite. And if you have a little experience on the MR, you're going to pick these up. So that is why I will conclude by saying that MR is clearly the gold standard. The only issue is getting a patient in and out, especially if basic is a challenge.
I agree, Dr. Johan. In fact, cardiac MRI, that is why has been coined the term as a cardiac histopathologist. Non-invasive histopathologist is a cardiac MR. And therefore, I think cardiologists and radiologists should come together to do a cardiac MR so that the understanding of when to apply, how to apply, what are the ifs, pros, cons, and caveats will be very, very clear over a period of time. I attended one of your courses actually, a year and a half ago. And I was quite impressed with that course, but it was 1.5 day course. So I think whenever your next course, I will definitely again definitely attend that. Thank you very much for being here indeed. And now one more question which I have for all of you all is the biggest roadblock in HEPREP therapy in India is starting and implementing guideline-directed medical therapy before the patient leaves the hospital after ADHF. And second is to maintain them on those therapies over months and years to come. So let us take the first point. How do we ensure that at least 2 or 3 of the 4 fantastic pillars are on the board before the patient leaves the hospital? And I can invite you one by one for this. Thank you. Yes, Dr. Johan.
We've been maintaining this heart failure registry at our hospital for some time. And what we have realized, which was actually a downer, is that cardiologists are not the best people to initiate these drugs and even to make sure it goes into the summary. Actually, our heart failure nurses are the best people. So we devised a very easy to use checklist. And this was also ratified by the heart failure group in the CSI. And if you remember, there was a very nice manual that was brought out. So we used that and made a template. It's a digital template on one of the girls' iPads. And she would do a routine round after we are finished and actually see the diagnosis of heart failure. And she would check whether any of the drugs are there or not. And in the next pro forma would be the reasons why it is not. So evening, before she would go home, she would visit us in the outpatient and say, "Sir, this is a patient, he's had an atrial MI, he's heart failure, but you have just started a beta blocker. There is no ARNI, there is no SGLT2, and there is no," and then I had to give an explanation that the BP is borderline, the potassium was high, creatinine is elevated, and that's the reason why. And the next day, she would be back again and say, "Sir, again, you have not done that." And then suddenly I realized that the creatinine's got better, the BP has improved. I said, "Yes, now I think we can get the ARNI on board." And she would relentlessly pursue us till the patient is discharged. And the discharge summary, again with the list, she would check again. And she would also check when these patients come back. We used to send these patients when they're waiting in the outpatient to her first. So she would double check whether the drugs are actually there, or if it was missed for some reason at the time of discharge, can we sort of get it on? It was actually a little frustrating and irritating, but we realized that we were absolutely well on course for GDMT by the end of about 2 to 3 months.
Yes.
Thank you.
Johan, in the European Heart Failure Society, this has been called as human alarms. These are human alarms, which you should have in every heart failure clinic, and whichever center is treating heart failure patients in majority or in large population of heart failure patients should have a dedicated heart failure clinic, and heart failure nurses, as we call physician nurses or physician assistants, as they call it, they have far more time at their disposal to do this checklist, so that they see when the patients go home, they are at least on 3 or 4 pillars of therapy. Now, Dr. Sanjay Mittal, how do you improve the adherence to therapy of these patients?
So
any of your tips or tricks for this?
Yeah, so my experience in my clinic for last 23 years or so has been that there are just very few things to remember when we are treating with heart failure. Whenever I'm taking around 1, 2, 3, 4, are there 4 things or not? And that is something to be done to them before discharge.
Yeah.
And that is the time to take some time to educate the person, because once the patient and the family learns why are these things being done and what is the long-term ramification of them and how to monitor, they have to be almost half a nurse or half a doctor themselves. And they learn to do it, and they actually come to us themselves to see whether when can we increase or decrease it. Secondly, every patient of mine has that access number of a specific dedicated email and a WhatsApp. And the nurses in the heart failure clinic, they are actually akin and in touch with those people for the first week. and then for first month, and then every 3 months thereafter, depending upon how the status of the heart failure has improved or otherwise. So it's basically a communication, a two-way communication, and make the family and the patient a partner to understand the disease process, and they become quite enthusiastic in actually continuing the medications and taking forward.
Yeah, thank you very much for that. I think this communication part is very, very important. Somebody need to follow them up telephonically, even by phone call, and ensure that they are taking the drugs regularly. Some member of the family, either spouse or daughter or brother or a son, should take the charge of the maintenance of the adherence to therapy of these drugs. And what is even more important, when they leave the hospital, these nurses, they should show them in some pictorial format how many years of quality of life and event-free survival will be added to their life if they continue with these drugs day by day, year by year, so year after year. So it's very, very important that way. So I think Neha ji, we are reaching the end of the time, I think.
Yes, sir. So we are almost.
Any other? Yeah, please.
So there is a question in the inbox. Yes. The question relates to iron deficiency only. The question is how frequently we should check for iron deficiency in a patient who has been once treated with IV-FCM.
I think that either Sanjay or Dr. Muralidharan can answer that, or both of you can answer one by one, I think.
Yeah, I think both of us discussed in our presentations that if a person has received iron therapy, we'll make a point to check it out again in 3 to 6 months' time.
Yeah.
And then just on 6 monthly basis, at least if everything is seemingly okay, every 6 months we should check it out.
Sure.
Okay. Thank you. Thank you, sir. Thank you. So with this, we come to a beautiful. Yes, sir. Yes, sir.
Yeah.
We would.
I thank all the faculty. They have done really, really wonderful job, and I'm really honored and privileged to be the chairperson of such an interesting program. Thank you very much, Sanjay ji. Thank you very much, Dr. Rotroy. Thank you, Dr. Johan. You have been always a pillar for our eco meetings with your beautiful lectures on cardiac MR, and of course, Dr. Muralidharan. Thank you very much.
Thank you, sir. Thank you.
Thank you, sir. Thank you.
I would request Dr. Swami sir to kindly give a vote of thanks.
So thank you very much, sir. At the onset, I would like to thank our chairperson and moderator, Dr. C.K. Ponde, sir, bringing a lot of discussion in this program. I also thank our speakers for the evening, Dr. John Christopher, sir, Dr. S.N. Rotroy, sir, Dr. Muralidharan, sir, and Dr. Sanjay Mittal, sir. Thank you to all the audience. More than 1,000 audience are logged in today. They were listening for this event across the country. Thank you very much for them. We are doing this heart failure symposium every monthly. So next month in the first week, we look forward for the next heart failure symposium with all the senior faculty. Till then, good night and goodbye. Thank you very much.
Thank you. Bye-bye. Bye-bye.
Bye.